Now, let's shift to Dr. Maryam, our amazing colleague. She has been working many years as a radiology consultant, and she is in Oman. Right now, she's doing her fellowship in McMaster in Canada, and she was also one of the amazing colleagues of FRCR certified radiologist. I think she is going to give us something very interesting in her field in the fellowship, and I wish you a good, enjoyable lecture with here. Dr. Maryam, are you ready? Join us.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
أهلا وسهلا دكتور محمود، كيف الحال؟
الله يرضى عليك.
الله يسلمك. So we will shift from updates of brain tumors to updates in ILD, inshallah. We will talk today about hypersensitivity pneumonitis. We will touch upon the updates on the ATS 2020 guidelines as a radiologist. This is the ATS 2020 guideline. It's the American Thoracic Society latest update on the diagnosis of hypersensitivity pneumonitis. The approach, according to this paper, was based on the clinical and the radiological diagnosis, but we would focus today on the radiology part, obviously. So, to start with, just a very easy definition of hypersensitivity pneumonitis. It's a combination of inflammation and fibrotic changes that can affect the small airways and the lung parenchyma. You might have only the inflammation at the early stages of the disease, and later on the disease, you also develop fibrosis. It is an immune-mediated disease that is actually caused by a culprit antigen. So there is an exposure, and this is really important. Why? Because when you suggest a diagnosis, your clinical colleague will try their best to identify the culprit exposure, because avoiding the culprit exposure usually will help the patient to resolve the inflammatory stage and stop progression of the fibrotic stage. Sometimes it's really difficult to detect the culprit exposure, and in those cases, we call it cryptogenic hypersensitivity pneumonitis, which is around 30 to 50% of cases. That is usually in the fibrotic type of hypersensitivity pneumonitis, because usually the non-fibrotic early stages of hypersensitivity pneumonitis is clinically easy diagnosis to make for the clinicians. So, update on the terminology. Previously, we were calling this entity extrinsic allergic alveolitis. Nowadays, we don't use this terminology anymore. It was also classified as acute, subacute, and chronic, but we don't use it anymore now. The important factor in the new classification system is to detect the fibrosis. So you would classify it either into fibrotic hypersensitivity pneumonitis or non-fibrotic hypersensitivity pneumonitis. The non-fibrotic one is the inflammation stage, and the fibrotic one is the one that have a combination of both the inflammation and the fibrosis, or a purely fibrotic end-stage hypersensitivity pneumonitis. This new classification really emphasizes on the presence of fibrosis because it can potentially be a reversible disease in the inflammatory stage. Some of the patients would have even complete recovery, or they would have a stabilization of their disorder. So what means that they will not have any progressive disorder, they will not develop fibrosis, which is an excellent point. However, the other category, which is the fibrotic hypersensitivity pneumonitis, unfortunately, the changes, the fibrosis is irreversible, but still diagnosis is really important. Why? Because there are because first of all, if you detect the culprit and you stop it, that can help the patient to stop or decrease the rate of the progression of the fibrosis. And nowadays there are papers that also recommend the use of antifibrotic agents also for the fibrotic diseases, fibrotic ILDs, not only the IPF and the UIP pattern. So this is the recommended HRCT scanning protocol. It is a non-contrast examination. They are using the lung algorithm, 1.25 millimeter, and very importantly, it includes expiratory imaging. So you take the first of all, you take the supine and expiratory phase, and then you take the expiratory imaging, and some of the centers would do it interrupted, and other centers would do it as a helical continuous expiratory imaging, which I personally prefer. And if it is a baseline evaluation for an underlying interstitial lung disease, it also includes prone imaging and inspiratory phase. Why? Because sometimes if it is a really mild disease and you don't have prone imaging, you will be really confused. Are those dependent peripheral changes in the lung posterior subpleural aspect true, or are these just gravitational and atelectatic changes? In that scenario, and particularly in the baseline imaging, you really need to have your prone. So remember, it's always important to have expiratory imaging as part of your baseline ILD protocol. And our talk today will be really based on the detection of the abnormalities on the expiratory imaging. This is a very common scenario. When your ER colleagues send the patient to rule out acute pulmonary embolism, but the patient also has an ILD. And if you do just a PE study to detect the embolism, you will not really know if the background lung has true ground glass opacities or that is just a parenchymal enhancement. Because when you get contrast, lung parenchyma, as any other organ, would also enhance. And this might obscure the subtle, fluffy ground glass opacities in the parenchyma. So what is the solution in this scenario? The solution is to have a non-enhanced chest CT before you proceed with your CTPA protocol. Some centers would do it as a regular non-enhanced chest CT and an HRCT protocol, which is really high dose for the patients having both together. Some centers would do it as a low dose chest CT without the expiratory imaging, but at least they can get an idea of the parenchymal changes that happens in the setting of ILD. So the article describes the various terminologies used for the heterogeneous lung parenchymal attenuation. And these are mosaic attenuation, as we all know. It's a descriptor used in the inspiratory imaging. It is to describe the heterogeneous geographic lung attenuations, where you have areas of hypoattenuations and areas of hyperattenuation. And this is confirmed on the expiratory phase to represent air trapping if it accentuates further. In other words, if the hypoattenuated areas that are thought to represent areas of air trapping are getting more lucent on the expiratory phase, that is a true air trapped area, and this is confirming the presence of small airway disease. But if it doesn't actually accentuate, but it does look like a heterogeneous attenuation, a mosaic attenuation on the inspiratory phase, we call it a mosaic perfusion. There is an important point here to keep in mind that the caliber of the vessels in the hypoattenuated areas that may look small and you think this is a vascular cause of this heterogeneous attenuation can also happen in the setting of small airway disease, because hypoventilated area will ultimately have a hypoperfusion, and that will affect the size of the caliber as well. Air trapping, as we described just now, is a descriptor that is used in the expiratory imaging to confirm that the patient has a small airway disease. three density sign or three density pattern, a famous terminology in the setting of hypersensitivity pneumonitis. Previously was called head cheese, but it's not anymore called head cheese sign. We call it now three density pattern. It's basically when your lung in the inspiratory phase has appearance or has really three densities. So you have the lucent lung, let's call it an easy terminology. You have the dark or black lung, which is the air-trapped lung. You have the gray lung, which is the normal lung, and you have the white lung, which is abnormal because of ground glass opacities. So you have three different densities. So it's really important in hypersensitivity pneumonitis to detect the presence of air trapping on expiratory imaging that can correspond to three density sign on inspiratory imaging or mosaic attenuation. This is an illustration of what I have just said. This is an inspiratory imaging, and we can see the geographic mosaic attenuation or perfusion, and we can discriminate by looking at the expiratory, as we said, and this is air trapping on expiratory phase. How do we know this is expiratory if it's not labeled? Just look at the posterior membrane of the trachea, and you see how it's anteriorly bowed. That is a good expiratory phase. It's really important for the CT techs when they do the scan to ask the patient to really exhale the air as much as possible to reach the end expiration, because early expiration wouldn't really help, and sometimes you will not even you will not be able to evaluate the air trapping. And this is the example of three density sign. We can see white abnormal ground glass area. We see a normal lung, and we see an air trapped lung. So there are two tables in the classification system for hypersensitivity pneumonitis according to the ATS 2020 guidelines. As we said, most importantly, to classify it according to the presence of fibrosis, so non-fibrotic and fibrotic. The non-fibrotic category and the fibrotic will have the two major subclassifications, which are the typical pattern and the compatible pattern. The typical pattern of non-fibrotic HP has to have one parenchymal abnormality and one small air disease abnormality. Parenchymal abnormalities, the dominant, the most important one to look for is the ground glass opacities. The small airway disease signs are, as we said, the mosaic attenuation, the three density sign, the air trapping, or the ill-defined small centrilobular nodules. It can be seen as sometimes peribronchial sub-6 millimeter nodules. The distribution will differ or will differentiate the typical from the compatible pattern. If it is diffuse in both the craniocaudal axis and the axial axis with some sparing of the lung bases, that's the typical hypersensitivity pneumonitis. If it has variable other distributions, without going into much details, it's written here if you would like, and we will have examples of this. It will be compatible with hypersensitivity pneumonitis. Just remember, if you are overwhelmed with these classifications, remember it's important always to say if it is fibrotic or non-fibrotic, if you can't really subclassify it further. This is the table that describes the features of fibrotic hypersensitivity pneumonitis, the typical and the compatible patterns. So what are the signs of fibrosis? We've been talking about fibrotic, non-fibrotic. So the earliest sign of fibrosis is reticulation. By itself, it's really difficult to call it fibrotic. So always look for traction bronchiectasis, or the frank sign of fibrosis, as we all know, is the honeycombing. So traction bronchiectasis and honeycombing. Distribution would differentiate both entities if it is, again, diffusely seen on the axial and the craniocaudal axis, if it is upper lobe or mid-lung zone predominant with relative sparing of the lung bases, this is typical hypersensitivity pneumonitis. If it has more central and peribronchial vascular distribution, on the axial axis, then this is a compatible pattern with HP. If it looks like another entity, let's say if it looks like UIP, but on the baseline imaging, it looks like HP, this is a compatible pattern with fibrotic HP, and we will have examples of these. If it doesn't look like HP, and actually the pattern on HRCT is suggestive of other entities, including UIP, and NSIP, or OP, then this is indeterminate for HP. This is just an example to discriminate between the fibrotic and non-fibrotic type. We can see that there is traction bronchiectasis, and this is definitely a fibrotic type, while on this image, we only see ground glass opacities, but there is no really traction bronchiectasis to suggest fibrosis. This example, along with all other examples I'll show you now, all from the Khoury Masterclass 2022 lecture in the Canadian Association of Radiology, and the acknowledgements goes to Dr. Michael McInnes from the University of Toronto. So, most important point to take from this lecture: when you classify HP, always state in your impression whether it is fibrotic or non-fibrotic, because that would determine the prognosis of the patient. Now let's practice. This is our first case today. We can see that there is a heterogeneous mosaic attenuation of the background parenchyma. We can see that there are areas of ground glass opacities, coarse reticulations, and traction bronchiectasis. Look at the apex here, look at the upper lobe, how tracted the airways are. This is mild fibrosis, but there is fibrosis, right? So this is fibrotic hypersensitivity pneumonitis. Because it's diffuse in upper lobes and in lower lobes, fibrosis are more in the upper lobes. This is typical fibrotic hypersensitivity pneumonitis. There is air trapping, and on the expiratory images, there was true air trapping on the mosaic. On the inspiratory, we have it here. It looked mosaic attenuation, but those areas got accentuated on the expiratory, confirming the presence of air trapping. So you have a parenchymal abnormality, and you have small airway disease abnormality, and you have fibrosis. This is typical fibrotic HP pattern. Surprisingly, less than 10% of fibrotic hypersensitivity disease have an upper lobe predominant disease. And this is really surprising for me, because HP is classically taught always as an upper lobe predominant disease, and that is how it is, and how it should be, and how you should think of it, as an upper lobe predominant disease. What they mean by this is that it can be diffusely distributed disease on the craniocaudal axis, with no definite predominance to the upper lobe, but sparing to the lower lobes. In other terms, it's still mid-lung zone or upper lobe predominant, but there is relative sparing of the lung bases. We have here the second case, and we can see that there are centrilobular ground glass nodules in the upper lobes and diffuse ground glass opacities on the axial axis as we go down in the lower lobes, and there is a definite area of hypoattenuation that is a true air trapping on the expiratory image. There is no fibrosis, so this will be a typical non-fibrotic hypersensitivity pneumonitis, and typical because it's diffusely distributed on the axial and the craniocaudal axes. Same patient on follow-up showed complete resolution of all the changes, and this is really good, because when you suggest a diagnosis, the respirology colleague will try to detect the culprit antigen causing this hypersensitivity to the lung and to the small airways. Avoiding that will result in some cases to complete recovery, as we can see here. Follow-up imaging may be helpful to ensure complete resolution of the inflammation. This is our third case, a very interesting case. So we see that there is ground glass opacities that actually extend along the bronchovascular interstitium. Look at that, how it extends along the airways and the vessels associated with traction bronchiectasis. This is a tracted airway. There is also maybe subtle traction in the lung bases, but it's really noted here. We can see that there is heterogeneous lung parenchymal attenuation, maybe a 3-density sign in the lower lobes, and there was area of air trapping or evidence of air trapping on the expiratory imaging. So this is a fibrotic hypersensitivity pneumonitis. This is the expiratory imaging, and it shows the areas of hypoattenuation, denoting air-trapped areas of the lung. We can see sometimes the expiratory imaging really are good to see the areas of the central ground glass opacities. They accentuate in the expiratory imaging, as we can see it here. So this is fibrotic hypersensitivity pneumonitis, and this is compatible pattern just because of the peribronchovascular distribution that we have just seen. Don't get overwhelmed. As I told you, if it's really hard for you to detect the compatible and the typical form, just say if it is fibrotic or non-fibrotic hypersensitivity pneumonitis. This is our fourth case, and we see that there is evidence of the ground glass opacities diffusely distributed in the lung apex. When we go to these two images, we see that there is also evidence of centrilobular nodules, and the background lung is also heterogeneous. The changes are predominantly in the mid-lung zone and upper lung zone with relative sparing of the lung bases. So this is a non-fibrotic because if we go back here, we don't really see areas of true traction bronchiectasis, and obviously there is no honeycombing. So this is an example of a non-fibrotic typical hypersensitivity pneumonitis. Sometimes it can be hard to determine if there is fibrosis or not. Don't look for the reticulations. Just keep looking for traction bronchiectasis or the frank sign of honeycombing. This is our fifth case, and it really shows how this disease is predominantly fibrotic. Look how much fibrosis in the lung. There's a lot of traction bronchiectasis, and it's more at the upper lobe, at the apex, at the upper lobe, and it's much more less as we go down to the lung base. There's background lung mosaic attenuation, and of course, at the areas of fibrosis, we see evidence of ground glass opacities and those coarse reticulations as well. And the expiratory imaging, there is evidence of true air trapping. Look how lobular it is, and this is the classical configuration of air trapping of fibrotic hypersensitivity pneumonitis. Sometimes if you see only 1 or 2 lobular air trapping in the lower lobes, just ignore that, it's not significant. Some literature say if you have 5 areas of lobular air trapping in at least 3 lobes, that is how significant we should quantify it for hypersensitivity pneumonitis. So this case is actually a typical case of fibrotic hypersensitivity pneumonitis. We have a 70-year-old man, and look at the abnormalities. It looks different, right? Different from the cases that I showed you. This case is a predominantly basal interstitial lung disease, peripheral interstitial lung disease, and the predominant feature is not ground glass opacities, but rather subpleural and peripheral reticulations. They're very fine subpleural reticulations. They present at the apex, but they are most pronounced at the lung base, what we call it the apical-basal gradient. There is evidence of traction bronchiectasis, so there is mild fibrosis in this disease. Expiratory imagings are not available, but there was no evidence of air trapping. How would you classify this one? So is this HB, or is this any other diagnosis? Actually, this is a classic probable UIP pattern, and therefore this is indeterminate for HB, but it is probable UIP pattern according to the 2018 IPF diagnosis guideline. This is an interesting case. 80-year-old man, presents with weakness and weight loss. HRCT reveals evidence of a mild burden, basal and peripheral predominant interstitial lung disease that is characterized by subpleural reticulations and areas of very mild traction bronchiectasis. If you are reporting this HRCT, you would say this is a probable UIP pattern, right? Especially given the 80-year-old man, very good demographics for an IPF, idiopathic pulmonary fibrosis, right? But always and always and always remember to look at the baseline imaging. Let's look at the baseline of this patient. So this one was in 2018, and look at the baseline from 2003. Look how the disease was. It was a 3-density cyan. It was a mosaic attenuation, and was true ground glass, a true air trapping on the expiratory imaging. So it was looking like HP, but now the disease has fibrotic component, and now it's looking like a probable UIP pattern. So what is this? Is it UIP or HP? It's HP. It's a compatible pattern with fibrotic hypersensitivity pneumonitis. Sometimes the patient will not tell you. For the clinicians, it might be really hard, particularly for the fibrotic hypersensitivity pneumonitis, to detect the environmental exposure on the culprit antigen. This patient had 20 birds at home, and that was the cause for his hypersensitivity. Let's have this interesting case now. This is a 55-year-old man. No air trapping present on the expiratory imaging, but let's have a look at his inspiratory imaging. We see an established, let's say moderate to severe interstitial lung disease that is characterized predominantly by ground glass opacities and traction bronchiectasis. We see that the disease is predominantly affecting the lower lobes. However, it's still affecting the upper lobe. The disease is not only peripheral in distribution, but has central extension of the ground glass opacities. No air trapping on expiratory imaging, and that should help us to say, no air trapping. This is unlikely to represent hypersensitivity pneumonitis then. The patient is a known case of dermatomyositis, and therefore this is a fibrotic NSIP pattern. So it is indeterminate for HP, and it's indeterminate by itself, suggests an alternative diagnosis. And in the scenario, it was a fibrotic NSIP pattern. Going back to that one, do you think it's really looking like the typical normal NSIP that we see? No, it's unusual even for NSIP. Why? Because it's very heterogeneous and has lots of central extension of the ground glass opacities. And classic NSIP pattern presents as a homogeneous peripheral subpleural ground glass disease with subpleural sparing in some cases. So when you see it very heterogeneous and having that unusual appearance, think of CTD as a cause of the NSIP. NSIP can be idiopathic, that is actually rare, but can be secondary to multiple reasons, including CTDs. CTDs like scleroderma, dermatomyositis, polymyositis, antisynthetase syndrome, or Sjogren's disease. It can also be secondary to some medications. Now, let's have a look at this one. There's very mild burden ILD. Someone would have even ignored calling this an ILD. It's really very minimal, right? It's a basal and peripheral predominant disease, predominantly characterized by fine reticulations. Maybe there are such areas of ground glass in the lung basis. Maybe there is some traction bronchiectasia at the periphery of the lung, but not really like frank fibrosis. So this, if you would have to classify it, maybe you would put it on a probable UIP pattern, right? But let's look at the expiratory imaging. There is evidence of air trapping and, there is evidence of air trapping. But okay, we know there is evidence of air trapping. Does the pattern here really look like HP? No, it doesn't look like HP. It's very minimal burden of fibrosis. So this was called indeterminate for HP. It was called indeterminate for UIP as well, as it was very minimal. And the one who saw that case said there is no evidence of fibrosis. If you don't have fibrosis, you can't call it UIP, right? So let's look at the follow-up of this interesting case after 2.5 years. What do we see now? We see ground glass opacities. There are patchy ground glass opacities, and the background lung is really heterogeneous. So it was very minimal interstitial changes, and now it has developed into hypersensitivity pneumonitis. And we can see there is a better appreciation of the traction bronchiectasia now compared to before. So this is a fibrotic hypersensitivity pneumonitis compatible pattern. It's really important to detect even if there is minimal fibrosis. Why? Because they will follow up the patient for any progression of fibrosis. And if the patient is rapidly progressing in terms of and degrees of fibrosis, then they will initiate the antifibrotic medications for them. Previously, it was only for IPF, but currently they also give these medications for various fibrotic types of ILDs. I believe this is our last case, maybe. So your ER physician calls you in your on-call and tells you he wants to rule out acute pulmonary embolism. You do a PE study, and then after doing the PE study, you figure out that this patient is an ILD. What to do now? Look at this. There is a carpet of very faint ground glass opacities in the lung, actually, right? But you wouldn't really be sure, because is that a true parenchymal opacification or a true ground glass opacities? But you can see the mosaic attenuation. You can see this lobular area of hypoattenuation on the lung base. Let's look at it. Yeah, that's a fact. Let's look at it on the follow-up when the study was done as a non-contrast HRCT protocol. Look how much more better you can appreciate those centrilobular ground glass nodules as opposed to the PE study. And this was a case of typical non-fibrotic hypersensitivity pneumonitis, because obviously we don't see any fibrosis, and that's a typical characteristic look for the centrilobular ground glass nodules. Is it acute? Is it subacute? Or is it chronic? Remember that this picture previously was called subacute, right? We don't use its terminologies anymore. So we don't call it acute, subacute, or chronic. We better characterize the presence of fibrosis. And that is the most important point to take home at the end of this lecture. I hope you learned something about hypersensitivity pneumonitis, and thank you so much for listening. If you have any questions, please, you can ask them.
Yes, please, Dr. Maryam, thank you for the wonderful lecture. And I have a question, please.
Thank you, Dr. Maryam, for this amazing lecture. We enjoyed very nice and very well from you, as usual. There is some questions.
Yes, I want to have. I have a question, please. Yeah.
Yes, go ahead. Yes.
Thank you, Dr. Maryam, for the nice lecture. Amazing cases. Regarding the classification of the typical and the compatible type of the HP, and if it's not compatible in the fibrotic type, why from the start, if we have the ground glass opacity and we have traction bronchiectasis in the base, and the picture from the start looks like UIP, for example, why didn't we call it from the start it's a UIP? Why we go for the compatible or a non-compatible type of fibrotic HP from the start? I mean, what's the difference in this classification in this part only? I mean, the last part looks familiar with the other entity like UIP. So it's from the start it's a UIP. So why didn't we call it a UIP from the start? If it's classical for UIP, why we go through the other classification for HP? It's I understand that if it's a typical one, it's okay. But if it's not typical, so we go for the other diagnoses as well. So it's straightforward. Why we go for the third column. I mean, there is any difference between the two classification, or we can go for it? I mean, it's the same if we say UIP and if it's fibrotic type, compatible type.
Yes, if I understand your question well, you are asking if this is a typical HP, you call it typical. If it is compatible, you call it compatible. And if it is not HP, you would call it what it is, like a UIP or NSIP or whatever. That's correct.
Yes.
That's the way it should be done, actually. This is just a classification system to say if it is not looking like a typical or compatible, you should call it what it is. Some centers would use these classifications. It's a bit confusing. I agree with you, but you can call it the way you want. Some centers would call it probable UIP, for example, without mentioning the ATS 2020 guidelines saying indeterminate for HP. Some centers would say it all, would give the classification according to the multiple guidelines. But I agree with you, this can be confusing, and it depends on the practice in your center. So if like the center I'm working on at, they don't use these different classifications. If it goes with one pattern, they would only specify and describe that pattern.
Okay, yeah. So the intermediate pattern, it means that you're not sure it's UIP. So you put it like this. You put it's indeterminate pattern, right?
Yes, if it is indeterminate for HP, in other words, you are stating that it is other differential. It becomes important when you don't have any other differential. Like
Yes.
it is indeterminate for HP, but you don't know what it is. Like you remember that case that I showed you, very minimal fibrosis that doesn't look like anything.
Yes.
And the impression in that case was indeterminate for HP, indeterminate for UIP. You did follow up, and then you have another pattern. Okay, so here it comes maybe helpful.
Okay, so the indeterminate cases would be it's not either a typical pattern or it's a UIP pattern. So it's in the between, or you don't know, or you don't have previous studies or other sequences or something like that, right?
Mm-hmm. When it is not typical or compatible, but you have other diagnoses, you specify the other diagnosis. When you don't have any other diagnosis and it is not going with HP, say it's indeterminate for either, and you would suggest doing correlation with BFTs, maybe on the follow-up, it will be more apparent disease pattern.
Okay, yes, understand now. Okay, thank you, Dr. Maryam. Thank you.
No worries. Thank you for the question.
Thank you.
Thank you, Dr. Maryam, again. It was really nice. شكرا والله. Very enjoyable يعني المحاضرة كانت ممتعة جدا we enjoy it يعني. Thank you so much يعني. We want to take a promise from you that you will continue this series.
شكرا جزيلا دكتور. إن شاء الله يقدر.
إن شاء الله. It's very nice and very detailed, and we like it. Yeah, inshallah, we would like to take it again and again, inshallah. So now time for break, and if you would like to take your coffee, اللي في السويد بيقولوا عليها فيكا ناخد كافي بريك until 4 p.m. inshallah. We start again at 4 p.m. We will have our lecture. Next lecture, it will be with Dr. Mahmoud. Inshallah. Let's see. At 4 p.m. inshallah, and we come back. Thank you so much. Dr. Muhammad Fuad, yes. Sorry, yeah. Dr. Muhammad Fuad, it will be an approach to meniscal pathologies in MRI at 4 p.m. inshallah. Just to remember again that we have simulation reporting at 7:30. Would like everyone to join this unique experience, and thank you.